Good morning. The Center for Community Investment is in the business of helping communities unlock the capital that they need to achieve their priorities. And I can tell you that in many of the places that we work, their priority is stable, healthy, and affordable homes for all of their people. And unlike Medicaid or Medicare, where you have an entitlement and you get it if you're eligible for it, housing is not that kind of a thing. And so what we're trying to figure out in our work and across our programs is what can we do to get all of the stakeholders who have an interest in these community priorities engaged in making them real. So 3 years ago, before we were even set up, the Robert Wood Johnson Foundation asked us, given the strong connection that has been demonstrated between safe, affordable, and healthy homes and good health, what would it take to have hospitals and health systems involved in making housing a reality? And the program that you see here described, Accelerating Investments for Healthy Communities, is the result of some research that we did for the Robert Wood Johnson Foundation that said, what are health systems already doing, even in this environment where the transition from volume to value is at such an early stage? And what we found is that, as in many things, I used to be a venture capitalist, the future is now, it's just not evenly distributed. And there are, in fact, a number of health systems, two of whom are represented here, that despite the environment that doesn't require them or even incentivize them very powerfully to do what they know is right, they're doing it anyway. And the program that we're running, Accelerating Investments for Healthy Communities, says, let's see what it would look like if we take the leaders who are already voluntarily stepping up to do the kind of work in affordable housing that needs to be done. Let's help them deepen that work and light a path for the other institutions that are interested in going further than they've gone. And what we found, actually, in terms of the motivations for doing this, is that the narrow focus on return on investment is actually not very helpful. Because as John Auerbach was saying, there really is an ability to focus on individual patients and reducing the costs of high utilizers and other populations that are homeless or chronically ill. And that's part of the story. It's a necessary and important part. But actually, the motivation of community health, or what some of the institutions in our program called institutional imperative, is really much farther reaching and much more important. And so when we talk to the people who are in our program, who are already using their assets to invest in affordable housing, what they'll tell us is once the connection has been demonstrated, which it has been, between housing and health, it's our mission to be in the business of fostering healthier communities. And so particularly for the faith-based institutions, but also for the safety nets and for the health institutions that have their own health plans, getting healthier communities is core to who they are as institutions. And so understanding that that kind of motivation of institutional imperative is just as important as the narrow financial ROI is really critical to making the case, we think, for this kind of investment. And as I learned once upon a time ago at Harvard Business School, when the CEO wants to do something, it becomes an institutional imperative. And so to the extent that we can make it the important and the cool and the necessary thing to invest in social determinants, that becomes what we do, and the narrow economic justification becomes much less important. What we've seen in our program is that health systems invest in a whole range of housing types. Those who tend to be more focused on the narrower ROI considerations tend to be on the left-hand side. They invest in homelessness, in supportive housing, in transitional housing. But what we're seeing among the leaders in our program is also an interest in a broader set of affordable housing investments, including family housing, affordable housing, housing for their own workforces, especially the people who are at the lower end of the spectrum, and a whole continuum of housing that allows people to move through the spectrum as their needs change. We've also seen that people have very diverse approaches. It's been said already that there is an entire sector called community development that spends all day, every day working on these factors. Health systems don't need to invent this work, they need to partner. And the partnerships can be quite broad, from community development corporations, which exist in some places but not others, to community development financial institutions, foundations, elected officials, and others. It's also important from the health system point of view to think broadly about the assets that can be brought to the table. Community benefit dollars are magic because they're grants, they can do anything. But we also see an awful lot of institutions thinking strategically about their land, some of which is not necessary anymore for the hospital's purposes. How can that be donated? How can that be master leased for affordable housing? We see them using their investment resources, pensions, foundation endowments, insurance reserves. And so thinking much more holistically about the kinds of assets that can be brought to bear really makes health systems a much more powerful partner in this field. What we've seen, and this has been mentioned already before, is that there are two levels of transformation that have to happen in order for this work to go forward. One is inside the health system, and we have wonderful examples here that you'll hear from in a moment of what that looks like, where the leader steps up and says, this is part of our business, we have to do it. There is a real need to go beyond the community benefits folks to bring a broad spectrum of the institution together as a steering committee. When we bring the financial folks who don't tend to know the community benefits people into the picture, they're able to think much more broadly about the asset base. We've seen the real estate people and facilities development folks come to the table with wonderful ideas about how to leverage land, how to master lease offices in strategic locations that can make buildings financially feasible. So it doesn't always have to cost money, and the extent to which a broad swath of folks are involved can help realize those opportunities. The other side of it, though, is the reaching out. So once the health system has decided this is something that we want to do, it's really important to have somebody to be able to partner with. And as has been said earlier, having the organizations in the community that can articulate a community vision for what needs to be done so that the health system doesn't lumber in and unintentionally cause displacement or things that are maybe the unintentional consequences of investment that's not done carefully is an important part of orchestrating this intervention well. It also is important to think not in terms of one investment, 100 units, 150 units, but in terms of a pipeline of investments that the hospital can help to develop and can help to create the partnerships that would bring into being more projects simultaneously so that we're not perennially in the catch-up mode. And finally, the health system has a role to play in convening a platform of these partners across the different types of institutions to meet on a regular basis so that people can come together and do this work. That's all we have time for at the moment, but I look forward to taking your questions.